And there are organizations that I know of that are not masking anywhere in their buildings until they start to sing, and then they go put on their mask. It's
Oh,
it's absolute insanity because
oh,
they've been, I know, isn't that crazy? And so in other words, they'll hang out together, socialize, eat together, talk about singing, and then as it's time to sing, they will then put on their masks.
just weird. Yeah. Oh my gosh. Wow.
Hello and welcome to the Choralosophy Podcast. This is episode 108, Dropping the COVID Ball with Dr. Nikki Johnson. This is the return after many months of a COVID Conversations episode. Sadly, many of us in education have lived at the epicenter of the COVID wars. Possibly the biggest political football during the entire pandemic in this country has been what to do with the kids and what to do with schools. For those of us in choral music, we lived at the intersection of that education fight, along with a hysteria created at first by our own very own professional organizations. This contributed to a perfect storm of lost positions, cut programs, recruiting problems, panic, and a laundry list of misplaced apprehensions about singing. Facts that I am still not sure we have all come to terms with. Of course, it is important to remember that in this crossfire were students and community members displaced from a life affirming and often life saving educational and humanizing opportunities. While it was always reasonable to weigh new risks against old norms, it is not reasonable to present our preferred policies, proposed by our preferred politicians, as if they have no downsides worthy of heavy consideration. In this episode, I speak with pediatrician and COVID policy advocate Dr. Nikki Johnson about the harm reduction approach to COVID policy, the political blinders we all wore or still wear, and many errors in reasoning to which this contributed. We also do a bit of prognosticating about ways to process in a more healthy way in the next wave. In the show notes, you'll also find a link, which I've republished on choralosophy.com, that is a reminder of the letter that this audience signed to send to ACDA as an appeal to fix their messaging. And since this is a look back on policy episode, I decided to put that in the show notes so people can read that again, just to kind of see where we've come from. It's a pretty interesting thing to look back at what we felt like and thought at that time. I've discovered that Distinguished Concerts International in New York, DCINY, is far and above the rest, especially for those of us from parts of the country that don't turn out for the arts in the way that New York does. Your students, your singers deserve that. I've had personal experiences with a few different companies that have done this type of tour, and I can tell you that it matters who you choose. It matters who you entrust your students' dollars, their time, their energy, and their hopes for a trip like this, because it's a big deal, and for the students, oftentimes it's a once-in-a-lifetime opportunity. Check out the offerings that they have there at dciny.org. So the month of May and early June saw the Patreon bursting at the seams. So go to patreon.com/choralosophy. People are loving those new coffee mugs. You can still get the hat there if you're on the merch tier. And I've even added a new tier because the producer tier is sold out. That is the folks that get that weekly shout out from me for their contribution at Patreon. That tier is sold out, so I've added a new one. So head over to patreon.com where all the action is behind the scenes for the Choralosophy podcast. Patreon.com/choralosophy. The show is produced on Patreon by Brannigan Lawrence, Chandler Smith, Vasquez Academy of Music, John Warner, Ulrika Igrain Munoz Alarcon, Angie Schilling, David Kowalczyk, James Mock, Jared Hendricks, Kyle Peterson, Jeff Wall, Michael Herron, Nathan Hines, Ryan Main, and Steve and Kathy Kakachik. All right, everybody, I'm here with Dr. Nikki Johnson, and I've been hoping to do another COVID conversation for a while, but also hoping I didn't need to. So this is a good opportunity to go back and look back at some of the policies and some of the places we've been over the last couple of years with COVID, especially related to schools. A lot of my audience is teachers. So this will be a great opportunity to kind of review some of the things and then look forward. So welcome, Dr. Johnson, to the show.
Thanks for having me, Chris. It's exciting. I'm with you. I was hoping that we wouldn't have to be talking about this in the summer of 2022, but nevertheless, here we are.
Yeah,
So,
yeah. In fact, let's actually. I'm going to put a pin in that for just a second, but because I first want the audience to just know who you are. So why
okay.
don't you just share a little bit about who you are and what got you to the point where you're thinking and talking about COVID policy in schools and with kids, et
Okay.
cetera.
All right. Well, the first thing I need to say is I am not speaking on behalf of the university that I am a faculty member at or the hospital where I practice. So have to get that out of the way first.
Absolutely.
Otherwise, I will be meeting in the principal's office again. Um, so my initial response in 2020 to school closures was a concern that with schools closing, kids would be missing out, number one, on education. Number two, kids I'm in Cleveland, Ohio, and I was worried about the kids in local, kind of public schools that would be missing out on meals and some social welfare checks that they normally get through school.
Mm-hmm.
And also having parents who had to work not being able to provide the childcare for their kids. So I was really initially very worried about that. And I think that our abrupt response to immediately close schools in March of 2020, when we at that time did already know from China, from Chinese studies, from scientists, that children were not being affected by the original Wuhan variant of COVID-19. So
in the same way that adults were, right?
Correct.
Mm-hmm.
In the same way that adults were. They were not getting sick as it wasn't being transmitted to children as much as it was to adults. Very, very low rates of transmission to children. And then children transmitting it to one another was also low at that time. Granted, we still had no idea how much disease was present in the United States at the time. We didn't know how it was affecting healthy adults. We knew, but we knew some of this information. We knew some of the information about who were the vulnerable populations. So starting back, well, and I'm board certified in general pediatrics and also pediatric critical care, which means I am trained in intensive care pediatrics. My primary specialty, though, is more like an anesthesiologist outside of the operating room, but I do work in a hospital, and I am part of our division of critical care. So I have eyes and ears and, kind of know what's going on in the ICUs. So we were not seeing kids being admitted. In fact, most hospitals were actually making room in their pediatric side for adult patients. And so we were having to slow down our volumes of patient care for elective procedures or non-essential, quote, procedures to make room for adult patients who were getting sick and hospitalized. And so this was frustrating for me. And I have been doing some advocacy for health policy for a few years now. And so I did have some ends in, kind of, having a public voice about this, in the form of op-eds, but not really, not obviously not a household name or anything like that, and not being, interviewed by multiple media, anything like that. But I was really concerned, and I did publish an op-ed in, I think it was May or June of 2020, when we were talking about schools reopening. And at that time, I was really encouraging schools to go to open back up. So that's sort of how I got started. But then many hospitals, including my own, made policies that prevented employees from publicly speaking out about against information that was being published by the hospital. So a lot of us who were in disagreement with the public health policy that was being made were essentially told to shut up
Mm,
and just kind of go along with it.
right.
And for me, that hardened and strengthened my resolve, because when I see something wrong and I know it, it's really hard for me to be quiet. And that's me. And so that's how I got into starting to make my voice heard.
Yeah. Wow. Yeah, and that's interesting to me because it seems like one of the things that we all grew up, or at least I grew up thinking about what science, air quotes, science is the idea that we don't arrive at a conclusion that we know is true or that we know has consensus unless that consensus is built over time organically. And your story seems to be the opposite of that, in the sense that you have a scientific institution announcing that consensus has been reached, but then blocking out the people that would normally be asked to contribute to that consensus, which are their doctors and the hospital staff. And, rather than, it just seems odd to
Yeah.
me that would be the process, rather than asking you all to share your opinion, shoot holes in our theory, tell us where we're going wrong, all that type of stuff I would think that would be your job.
Yeah. And, at the time we were having discussions in the hospital with things, but we weren't, I guess I would not say that we were all equally represented, either in public health forums, in, statewide, local forums, either. So
Mm-hmm.
your assessment that it was a scientific consensus was reached, without any science to back it all up, it pretty much summarizes the last 2 years for me.
Yeah.
Some other things that started happening too that really made me fired up were, we started seeing, there were people who were early on adopters of hydroxychloroquine, sorry, being a treatment or a preventative or an early treatment goal. And then, ivermectin sort of came through later, and there were a few others. And, for me, I wasn't, 100% convinced, but I was seeing a lot of my colleagues and, meeting in, email chains and group email chains, and people who were actually treating patients with COVID, seeing patients with COVID, they were using these medications and they were claiming to have success. But then our state pharmacy board made a public statement that they would deny any prescriptions that physicians made for hydroxychloroquine for the diagnosis of COVID. So they required you to put a diagnosis on the prescription, and then they would deny it. So essentially, the Board of Pharmacy was basically interfering with the patient and physician relationship,
Mm-hmm.
whether or not it was scientific or not. Hydroxychloroquine is a very cheap medication. So is ivermectin. Both of them have been FDA approved for human use for many, many years. And they are safe. They have great safety profiles. Whether or not they are beneficial to COVID-19, is up for debate. But if people were electing to use it, basing that on some sort of, scientific evidence that they had of their own or some reasonable theory, there's no reason that the government should be intervening, or anyone who is outside of that patient and that physician relationship should be intervening, as long as that doctor is providing informed consent to their patient. There is no reason for anyone else to get in the middle of that. And that infuriated me.
Yeah.
I'm not like, I don't practice that kind of care. So I'm not prescribing those medications. I have colleagues and friends who do, and are on the front lines, and they're seeing patients in their clinic daily, and they need something to treat them with. And while hospitals and doctors' offices weren't even willing to see patients in person unless they were really sick and needing to be hospitalized. So to me, that really got me fired up, and I was just really concerned about the direction it was all going. That started, to me, what I see as a politicization of medical care
Yeah.
and of the pandemic itself, and that has been made evident over the last 2 years.
Now let me see if I can summarize your beef, and you tell me if I'm giving it back to you incorrectly. So it sounds like
Okay.
your beef is not necessarily that it was a slam dunk that those types of medications were the right thing to do. It's just that by shutting it down with those third party, government or other institutions, that's just not the normal procedure for that. So it was almost like they were skipping the scientific steps that it would take to reach out to doctors and say, hey, you should stop prescribing this. Before the pandemic, there were other ways that would have happened. Is that accurate?
So close. It's not always necessary to have a scientific discussion about the merits of any type of therapy. If there's a theoretical, reasonable approach to using a medication or a therapy based on past scientific data, or knowing the mechanism of action of the pharmaceutical agent or treatment, then and it's reasonable to assume, then many medications are used what we call off-label. So the FDA labels it for a specific reason, but doctors can prescribe and use the medication for another reason, as they see, it's necessary. We do this all the time in medicine. And in being on the pediatric side, the majority of medicines that we use in peds are FDA approved for adults and not for kids. And we still use them because we know they work. And we dose based on weight. This is something I practice daily. So it is not unusual for medications to be prescribed off-label without having some major scientific discussion about it. This was fairly new to see this opposition and this interference coming from government officials and public health, and also the rest of the scientific community, because it wasn't just them. There were publications, medical journals publishing data saying that these medicines don't work, with poorly done studies also, just to what I perceived as being oppositional to something based on political reasons. And then you also saw preference for medications that were new, expensive, only administered in the hospital, and were in the middle of being studied, going through trials for patients. Remdesivir is a great example of that. That medication was, and many of the hospitals were treating patients with it as a part of the research for treatment for COVID-19 infection during that time.
So
and
a bit of a
that
double
was
standard.
rated as, yeah. So
Yeah.
there was a double standard. You were using a medicine that was being approved for research purposes, and it was an emergency approval for research as well, when you already, and that was only for patients who are admitted to the hospital. So there was nothing being used for patients who were outside of the hospital to prevent them from going into the hospital in the first place. And so yeah, definitely a double standard.
Yeah. Let's jump into schools.
Okay.
And I want to kind of give you my memory, and I want to have you react to it. Don't forget the Choralosophy discount code. Enter Choralosophy at checkout at mymusicfolders.com when you get your singer's masks or your choir folders or your choir robes at mychoirrobes.com, as well as sightreadingfactory.com, and when you get your sheet music at graphitepublishing.com and ryanmain.com. That Choralosophy discount can be saving your program hundreds of dollars a year. Make sure you're using it at all those vendors every single time. Don't forget, I am teaching a course at the Modern Conducting Academy. And if you are not a member of the Modern Conducting Academy, head over to choralophymca.com and get signed up for a year membership. Choralosophy listeners get a month free if you do that. And of course, you'll be able to access my course, The First Days of Choir, along with Dr. Joshua Haberman's course, Growing Your Numbers Through Storytelling and Programming, as well as all the courses that have been taught by folks like Maria Ellis, Jerry Blackstone, Pearl Shengquan, Don Brinegar. The list, it just keeps growing. Head over to choralophymca.com. So as a public school teacher, I've been teaching for 20 years, and I, of course, watched the world shut down schools in March, and I was flabbergasted because I saw a lot. Started following the science of it pretty closely very early on, and started noticing the same things that you noticed earlier about the Chinese data and the outsized effect on adults versus kids. And I also noticed, and I'm going to put this document in my show notes, but I also noticed that Europe seemed to prioritize very quickly, how quickly can we get our schools back open? And they had, for example, I'm going to pull this up and just read you some numbers and see if you remember this. But let's say, all right, Denmark, for example, they only kept their schools closed for 2 months. Germany, 52 days. Greece, about 60 days. Norway, about 60 days. Poland, about 70 days. Sweden never closed elementary schools at all and kept their high schools open. Just as an example, I started noticing these things because, of course, I want to get back to my kids. And so I'm noticing this stuff happen. And then over the summer of 2020, I was super excited because I saw a mainstream, I think it was one of the main news networks, CBS or NBC. I can't remember which one it is. I'll try to track down the video for later and put it in the show notes too. But there was this montage of pediatricians and epidemiologists, and they were asked the question, are you sending your kid back to school in the fall? And it was all like, yes, absolutely. I'm going to send my kid back to school in the fall. And there, I don't know if you remember this video.
I remember that.
Yep. And then not only a few days after that, Donald Trump got on TV and said, we got to get schools open in the fall. And I went, oh shit. That was my first reaction, because I know how much the teachers unions hate Donald Trump. And so my first thought when I was watching it live, and I looked at my wife on the couch next to me, and I said, we are not going back to school in the fall.
That did it.
That's what happened. So I want to share my screen with you because, and for people who watch this on my YouTube channel too, I'm going to share this with you and get your reaction, let you go ahead and take a crack at this from your memory. So this is school closures. Red means they've got places that have like completely closed schools. And then green is no measures. You can see the yellow and red or orange kind of in between. Watching what happened as I scroll through. Of course, China closes first. And then we follow closely behind. Then, of course, everybody freaks out for the most part. As we move through time, watch how the world starts to react to changing COVID levels while we don't. Okay, and this ties into, I'm going to go all the way to now. This ties into what we were talking about right when we started talking about this false idea where in the U.S., where we were led to believe that there was this like consensus on this topic of kids in school. But then if you look globally, I think I made my point there, and I'll link that in the link that in the show notes. There wasn't a consensus. There were scientists all over the world of all different skin colors and all different nationalities and backgrounds looking at data and making different decisions about what they were going to do with their kids in schools. But we were told there was an answer. And which is that it is not safe for kids to be in school, and that if you try to question it, then you are questioning the consensus. And then, of course, you look back at the history of the last 2 years, and that's just false.
Well, and if you go back, we were not told that the kids were unsafe. It was opening schools was unsafe for the teachers and for the kids' parents and grandparents. So kids missed school because they were being used as human shields for adults. That is the absurd part of this. That is not often discussed. The other piece of this is I recall, I can't remember the exact date, but this was definitely well before the 2020 school year restarted. I know that I looked at data that was published by the Netherlands, looking at some European schools that had gone back to school and looking at transmission rates. And it was all kind of just database driven, loosely, kind of loose statistics. But the schools, for the most part, had opened back up without any restrictions. Children were not necessarily transmitting to one another in high levels, but they were, and if they were transmitting to one another, it was within their own peer group. They were not going home and then bringing it to the adults. And then of course they weren't getting nearly as sick, and hospitalized as adults were. So that was really good, preliminary data that showed that this was pretty safe. And they had been in school, for, several months at this point when they published. Any person at the time who suggested that kids go to school on social media or, any kind of public forum was basically accused of wanting to kill grandma. And so we weren't really, there were some of us were out there really saying this, but the loudest voices were interviewed on major media outlets and were allowed to be the voice. And honestly, I think that it wasn't necessarily public health officials that made this general consensus. I believe that the media, the national media, made the consensus by picking and choosing the voices that they wanted to hear. And those voices were pretty much anyone who opposed Donald Trump. And that was and so that point that you made about school closure, when Trump, I remember this distinctly. And the other point of the other piece of that was the American Academy of Pediatrics did come out with their statement saying that they thought that schools should definitely be opened in the fall of 2020. And then they retracted that statement. And now we know that they were pressured by teachers unions who pressured the CDC. But it all unfolded after Donald Trump said everything. Everybody backtracked their statements, and there was a congressional hearing with leaders in public health at the time. And I remember that Dr. Redfield, who was the head of the CDC at the time, did recommend that schools reopen. He was the only voice recommending that schools reopen, and he wasn't listened to.
Well, he not only that, he was ridiculed.
Yes, he was,
as not being a legitimate expert or whatever. Which of course is the trick that was played the whole time. Was that okay? How do you build a consensus if there are experts who disagree with you? Is you just say that those weren't real experts,
right?
And so then you get to keep your consensus.
Right. Or you accuse them of being a racist, misogynist, Trump-loving, anti-democracy person, like whatever horrible name you could think of as the lowest person on the earth, you label them with that, and then that destroys their credibility.
Right. Yeah. And I think what's interesting about this is that similar patterns can be established with the way people think about or thought about masking in schools, and at the population level too, but in particular in schools, where there was this idea that there is it's just an obvious answer, like that masking in school would obviously and scientifically proven to be effective, and then they would point to, well, in fact, I want to shout this out too, because you eventually signed on with Urgency of Normal, which is a wonderful advocacy group, and I'm going to link that toolkit in the show notes as well, so people can look at this. But one of the things that's pointed out in there, for those of us who are not science people, science teachers, is that the conversation about masking frequently got confused because of the lack of controls. So it's almost like we tried to prove masking in the same way we prove social science, which is very, very difficult to replicate, obviously, because if I'm studying the behavior of people, there are so many variables that can affect that. Here's a good way I think about it, which is that, like, if I try to take a study of masking in one area, and I look at only that masking variable, did we mask or did we not mask? And then I look at another area that, that didn't mask, and we compare the data in those areas. If the only variable we're looking for is masking, then we're going to confound the study over and over and over, because the behavior of those people, maybe the weather was different. Maybe they stayed inside more in one area. Maybe one area has a lot, like a more dense population than the other area. There's tons of things you have to look at beyond. So as a non-science person, how am I doing so far? Is this making sense?
Yeah, actually pretty good. And so one of the studies that the CDC's MMWR, like that their publication, scientific publication put out, that said that schools that masked showed fewer incidences of transmission of cases, was highly flawed for this very reason. There are multiple reasons in the study that things that confounded it. One of them was that kids who were masked in districts, if there was a positive case of COVID in the school, the kids who were masked were not treated as being a close contact. Only kids who were not masked in schools that were not masked were considered close contacts to somebody. So you threw out the possibility of kids transmitting it to themselves, to other kids, even wearing their masks. So that's part of the data that's flawed. You also don't consider vaccination in that group, because vaccination, while it's not a perfect preventive tool for transmission, it does offer some protection from, some benefit to, preventing transmission. It's not great. But so if you don't take those into account either, you're also confounding. So that was one study, and that study was actually used by Rochelle Walensky multiple times as proof that masking in schools work. And it's not. And then there's been subsequent studies also that have showed kind of a mixed picture. And that is because they didn't really use any kind of real world scenarios where, people were actually, some were masking, some were not masking, and what were the transmission rates. So lots of confounding factors in all of those studies, but we have seen a few that have demonstrated that masking does not offer any protection of transmission that's significant, or not even that, the secondary transmission, which is I give it to you and then you give it to somebody else. And so we know that masking really doesn't work, especially for kids in schools. So we do know this now.
Yeah. Now, I want to add a point of clarity, and feel free to push back on this. This is something I've been really passionate about over the last year and a half, because on this show, one of the things that I've done is advocated for the idea, and even as a promotion, I've been selling what are called singer's masks, which are designed to stay sealed around the face as your face moves. And the company that I sponsor, or that sponsors the show, that made those, did a lot of work with legitimate scientific labs to study whether or not those are providing filtration. Because one of the things that's interesting is that when you like what you and I were just saying, when we say masking at the population level just doesn't work, is not the same, in my opinion, as saying that you can't mask in a way that works.
Exactly.
But the issue. Yep. But the issue is that most people don't. And so when you study masking at the population level, even having a binary on your study that is masked versus unmasked is confounding in itself, because what does mask mean? Mask could mean anything.
Correct.
they're not going around and looking at how much it's covering your nose or not. Maybe there's gaps all over. Like it only takes like a 5% gap
Right.
around the edge, and the mask doesn't work at all.
Correct. And
Um, yeah,
they
go ahead.
didn't, and not looking at type of mask either.
Mm-hmm.
So types of mask we know makes a difference. Cloth masks essentially do nothing.
Mm-hmm.
And the surgical isolation masks, or those paper masks that you see, are a little better. And then, of course, anything that's, a higher filtration, 95% or above, like your typical KN95 or N95 mask, those offer a lot more protection but again, like you said, the caveat, there needs to be a proper seal around the nose and the mouth so that there's no air that leaks out. And so, but the main protection offered in masks like that is for the person wearing the mask, not the people who are around that person. We don't have a lot of great data that shows that you masking is protecting the next person.
And
The other
that's
piece
hard.
of that,
Yeah, sorry,
yeah,
I'm gonna jump in for a second.
yeah,
So, because that point is really important, because common sense, non-scientist thinking through that. If I'm thinking about how I breathe out through a mask, that air's got to go somewhere. If that air
correct,
was being trapped into that mask, it would be blowing up like a balloon. It's
yeah,
it's coming
right,
out, right? And
right.
so the question is the quality of the filtration of the mask itself, and is it being worn correctly? So I'm a singer. I do choir. That's my
Hmm.
job. And of course, choir people famously freaked out about singing during the pandemic.
Yeah,
And there were
yep.
news stories about it all over. In fact, choir organizations led the charge for this. So there, even as we speak, there is a choir organization having their convention right now, which is mandatory triple vaccination and mandatory masking in 2022. And there are organizations that I know of that are not masking anywhere in their buildings until they start to sing, and then they go put on their mask. It's
Oh,
it's absolute insanity, because
oh,
they've been, I know, isn't that crazy? And so in other words, they'll hang out together, socialize, eat together, talk about singing, and then as it's time to sing, they will then put on their masks. And it's for the
just weird.
science. It's for the science.
Yeah. Oh my gosh. Wow.
And
Wow.
so this is kind of what we're dealing with, and one of the things that's been difficult is to get people to understand what I was kind of explaining before, where so let's say I'm wearing an N95. An N95 was tested for filtration by essentially attaching it to a tube with tape around the edge and then blowing air through it, and then it measures
Yes.
how much filtration. But they never tested it on a singer like me with a beard, dropping my jaw so that my mouth hangs wide open, and then
Yep.
and as I do that, it breaks the seal around my face. And so, like, so then someone says, well, why can a doctor wear the mask in the hospital and you can't wear it while you're singing? And I'm like, well, because the doctor's not singing. Like,
Right.
these are confounding variables.
Only as pediatricians, we sing it and have fun at work.
Oh, do you? That's
But
good.
well, speaking of the doctors in the hospital, so this is puts it in another perspective. Prior to 2020, when I would go in to see patients who were sick with a virus. So for us, prominent viruses for kids were RSV, and or RSV bronchiolitis, and influenza, and just some other cold viruses that are making them sick and have to be in the hospital or in the intensive care unit. We never asked the patients or the families to mask ever. Why? Because they weren't they were sick. So they were already sick, and they didn't need to be protected from getting sick. So we didn't ask them to mask. When we went to see them, we used whatever precautions were appropriate for that type of viral transmission. Bacterial as well, tuberculosis, same thing. If people are sick, if they're able to transmit it to you, then you protect yourself. So
Hmm.
healthcare workers, nurses, and doctors go into the room, wear a gown, gloves, mask, goggles, in N95 if it's appropriate, depending on what the virus is, or the type of transmission is. Um, and we were not seeing people spread virus throughout the hospital, and doctors and nurses weren't getting sick because who took those precautions were not getting sick.
Mm-hmm.
And so now to all of a sudden have this new consensus that everyone must wear masks at all times to prevent each other from getting sick and prevent themselves from getting sick is antithetical to every single thing that we knew prior to 2020. And it's not because there's some new dynamic research has happened that has changed that thought. These are decades of studies that showed us how we should be protecting ourselves and protecting our patients while in the hospital from spreading throughout the hospital. And all of a sudden, we're just told to ignore that. And it's just, to me, it's insanity. I can't find a better word to explain it at all. It is become more like a cult-like behavior, and it's astounded me. It's made me really question a lot of consensus that's out there now about a lot of things.
Mm-hmm.
Which is one kind of a great thing, because as physicians, and scientists, we should always have a questioning nature anyway, and we should always be looking for the evidence for why we do things. But just because something was consensus in the past, we shouldn't automatically accept that all the time. And so it's a good thing that, it's gotten us to be more questioning and wanting to look and making sure we're doing the right things. But the second part of it is it has made us not trust the institutions that we could once trust to give us reliable scientific information
Mm-hmm.
and guidance.
Right. Yeah, because I think one of the first things that turned me off to that type of obviously false consensus claiming is that if I just naturally would trust a person in general about whatever topic it is if their communication style was more open, in the sense that, like, hey, I recognize that I don't know everything. Here's what I think is
Yeah.
happening. But if you disagree, you're welcome to share that with me.
Yeah.
That to me is a posture of openness that is more trustworthy. To my,
Yes.
maybe that's my personality. I'm not sure, but and when I started seeing the opposite of that, I immediately bristled to those types of things, and that's again just as a layperson. But I want to say one more thing about masks before we move on from that, and see if you agree. Another thing that, because of the research that I personally did in order to throw my name behind a singer's mask, I kind of looked at, are you familiar with the resources at CIDRAP about masking? It's
No.
University of Minnesota. It's their like fluid dynamics lab. Michael Osterholm is in charge of that. And it's kind of one of the authorities on the science of masking going way
Mhm.
before the pandemic. And one of the things that is interesting is that by looking into that resource, which is very thorough, I came to the conclusion that, kind of with the help of that resource, that masks work and masks don't work. What
Yeah.
changes it is it depends on the context. So, for
Right.
example, you mentioned, I love the example you used about healthcare before the pandemic, where if someone was already sick, you'd go into the room to treat that patient and you'd protect yourself. Well, I'm just guessing, unless it's like a highly contagious, highly deadly airborne pathogen, you would have worn a surgical mask, because that's like a droplet precaution kind of a thing. And
Yep.
you would probably not be hanging out with that patient for like 3 hours. You'd probably be going in
Correct.
there for a little while, which means that in the healthcare settings, you are using the mask the way that it was designed, which is to give you about 30 minutes ish
Yep.
of moderate protection, and then you're getting out of there. Whereas now, what health policy did at schools in particular, to take it back to schools, is they told kids to go for 8 hours into a building and share air with people
Yeah.
wearing any kind of mask you feel like.
Hmm.
And we're not supposed to question that's effective. That's horrifying.
Yeah.
Especially if you have
And
actual kids that are immunocompromised being told that they're safe because they're wearing a neck garter on their face.
yes. Yes. Yeah, that was, and and rewind even back further because we didn't have access to isolation masks or N95 masks in the beginning of the pandemic. Remember, that was a huge supply chain issue, which was another part of our failures in planning for this. And we're seeing a lot of that unfold now in other forms of the areas of the supply chain. But we didn't have that. So kids were going to school with basically wear any kind of covering. I mean, you had the Surgeon General, the US Surgeon General on television cutting up a piece of, t-shirt and showing people how to make that into a mask. So it was pretty much anything. And then you're taking kids at all different grade levels. Now, most kids are pretty compliant and they will do what you tell them to do. They follow instructions. And even if they're constantly reminded by their teacher, they will do it. But then that means that kids are touching their mask all day long. They're pulling it up, pulling it down. But then the only real break they ever got from the masks was during meals, in which they also had to sit distanced away from their classmates and teachers. Or they had to eat outdoors, which was insane in extreme weather in New York City. I remember hearing some stories that just were horrific. Had to do that. And then go back in and put the same mask back on. Well, after they were done eating. And then go home, come back. And most of the time, if it was a cloth mask, I can guarantee you they weren't washing the mask. So whatever debris was on the outside of it the day before, they were bringing it back to school the next day. So there were just lots of things wrong with that initial response and what we actually told kids. And that then translated to lots of kids believing that they're safe by doing that. And like you mentioned, the immune compromised kids, and then that they're also protecting other people. And then in this form, we basically told them something that wasn't true and they believed it.
Yep. It's misinformation.
And we're now 2 years into it. And there are some who still believe it and won't take their mask off because they feel like they're doing the right thing while wearing their mask.
Right.
It's
well, and here's the people who are still masking. This is kind of my message or my thought process for them is that if you're still masking because you have some type of a legitimate high risk factor, then please be wearing an N95 correctly.
Correct.
And go figure out. Go to CIDRAP. I'll post the link in the show notes for that too, of how to do that, how to correctly do that, and how to verify that you're doing it. But what I don't have any respect for anymore in June of 2022 are people who are loose cloth masking just to show that they're masking. Because we know enough now to not make those types of decisions. Or don't wear a surgical mask while you hang out inside for 8 hours with someone.
Correct.
Because by that point, you are sharing air.
Yes.
And it's okay. It should be okay to
wearing
explain
a mask is not a sign of virtue.
No.
It is a sign that you don't want to be sick. So if you don't want to get sick from any infection that's airborne or spread with droplets, then you should wear the proper mask and have it fitted properly and wear it in a way that you are putting it on and taking it off in a way that you are not transmitting disease to yourself. And so that is where the emphasis needs to be. And children are not are shields for adults. Adults who need to be protected should be protecting themselves from infection, not the children.
Yeah.
Not relying on children.
I started thinking about that right away. I'm only in my 40s, so I don't have grandkids yet. I'm not really in that high risk category. But I started to think about if this pandemic had come around 40 years from now, when I was 80, you would have to lock me in my room before I would allow someone to sacrifice my grandkids for me.
Yep.
like that over my dead body.
Yep.
Yeah, and literally, because that is the risk level for people in their 80s. But I couldn't understand right away why we were doing that. Like because the every ounce of me as a father is trying to figure out how to make my kids' lives better. And
Yep.
you're exactly right. We started using kids to shield adults, and in education, that was really strange to me too, because most educators on average are my age, and very few of them are
Yeah.
six. Very few of them are 60 or over, like a tiny
Right.
percentage. And so we were also relatively low risk, and then we got to get vaccinated like first. We were
Yes.
like one of the first groups to get vaccinated, and we were still reasoning in the same way. And I
Yep.
think I think part of it, and this can maybe be the transition into the last part of our conversation, where we think about like where we're going with all this. But one of the things that I think one of the mistakes we made in our national discourse early on was we started allowing the reasoning to be based on this "if it saves one life" thing,
Yes.
because that implies that there is a zero risk scenario that we could get to.
Yes.
And I noticed that right away, because I said, my goodness, there is no such thing as zero risk. If our goal is zero risk, we will be doing these things forever. And
Well,
some people still are.
yeah. Well, I mean, not only is zero risk impossible, of disease impossible, but to save, if we do one thing, um, to save one life, how many lives are we affecting negatively by doing that?
Hmm.
And that means that we have not considered the cost of saving that one life. Even if you think it is something very simple, like putting on a mask, how much is that going to cost? And that's one of the things that urgency of normal has been, for me, being a part of that has made me proud, is that we've been able to actually look at the cost of that, for at least for children, and concerns that we had in the beginning of the pandemic about school closures and those effects that they would have on kids' literacy, learning, welfare, social welfare, emotional and psychological state, are now being realized. And this is one of those times where I hate to say, I told you so.
Hmm.
This is something we could have prevented. And that to me should be our lesson. But oh, nationally, I don't think that we're learning that lesson, because there are still people who are heavily invested in those early decisions, and continuing some of the same practices. I mean, right now it's still up in the air if there's another surge next school year, whether or not they're going to close schools. It's not a definite thing. And
Hmm.
I'm lucky. Well, I'm pretty blessed where we are. My daughters are in private school. Their school opened back up right away. They were fully prepared to kind of keep mitigating diseases. They ended up having a resource that was like the COVID hotline type of resource. So we had that available to us. But while they were going back, the kids in the public schools weren't back in school.
Hmm.
And they were sitting at home, and I'm hearing teachers tell me that kids are falling asleep or not showing up to class, and because there's no parent there. Just all the disasters and the nightmares, and the anxiety disorders and depression and things that we are seeing rising in young and adolescents, um, because of our policies, are things that we could have prevented. And then to me, it's a huge failure as adults. It's our responsibility to protect kids. And I just don't think we did that.
Hmm.
So I, so that's why I don't, this isn't over for me until we have figured out how to respond to something like this the next time it happens. And COVID-19 is not the only virus that is a burden on society.
Right.
RSV bronchiolitis is actually more infectious and more likely to land a child in the hospital, especially a child under the age of 5, than COVID is. And they're more likely to die from influenza or RSV than they are with COVID-19. The mortality rate, the hospitalization rate for COVID and influenza is about the same when you kind of look at averages over the last 10 years or so of influenza. And so, we're making these changes for one virus when we have no precedent with viruses that are just as deadly or even deadlier to kids. So where are we going to go with this is something that we need to make sure that we prevent from happening again each season as viruses of all types surge.
Right. Yeah. One of the things I'm comfortable saying is that one of the lessons that we should have learned, and I hope that many have, but I'm not optimistic that enough people have, which is that we should be looking at a harm reduction overall approach to healthcare and to
Yes.
public health. And I know you agree with that. That's very much part of the urgency of normal packet, which is that the idea that you can't just look at one disease, like you mentioned, and then try to reduce the level of harm for that one disease without looking at the possible downstream effects of all those things that you're doing. So I can I can share with you a personal story about that I think crystallizes that. During the pandemic in 2020, my wife and I lost my mother-in-law, her mother. She passed away from breast cancer in 2020. And one of the main cause in my mind of what happened in 2020 to her was that in March of 2020, when everybody was really scared, she for the first time felt a lump in her breast, but she was so afraid of COVID that she wouldn't go get it checked out. She wouldn't leave her house, and she died in September because she finally went out in August and got it checked, but it was too late at that point. It was fast. And had you can't go back and say for sure that if she had gone in March or April that they would have caught it in time, but you have to wonder, is she an example of someone who was a casualty of fear of COVID? And that's just one example, because there's probably tons of examples of things like that.
Yeah, people were dying at home with heart attacks because they weren't going in with chest pain because Yep.
And a harm reduction approach would be to look at all of those things as if they're equal, as if her life is equal to a person who dies of COVID, that those are equally concerning.
Yes, absolutely. And we have to look at the whole life, the whole perspective, all of society's benefits and costs when we make these decisions. And they shouldn't be these kind of blanket decisions. We've affected everything. Just by our response. And we've seen on the positive side, we saw that some of the European nations do a lot better because they did take a strategy that was focused more on the people who were vulnerable to getting serious illness and didn't use children as human shields. So for the kids, but lots of lessons that we can learn. And I can't say that I am an optimist. And so I do hope that we do take away those positive lessons from this, but I'm very pessimistic about the leadership in this country and the approach that they're taking. So that it has become way too politicized. And I don't know how we go back from that, except that for me, being a part of urgency of normal, we're of all different political stripes, but we believe in the same thing. And so to me, there's hope because of that.
Yeah. Yeah, that's wonderful. And I would say, I'm going to kind of make one more comment, and I'll give you the last word, and we'll wrap this up. But I feel like one of the other things you mentioned, Europe did a better job in a lot of ways, and I showed that map earlier, and that kind of indicates too. But same thing with masking, and really with every type of COVID policy, the U.S. seemed to. Yes, of course, we in the U.S. we have different states with different levels of precautions that were happening throughout, and I recognize that. But as far as our national conversation, we seemed to react more slowly to changing information. Whereas in Europe, even school masking, it would be like if they do mask, they were going to mask for a few weeks and then they'd take them off, and they would react to what was happening with COVID. Whereas we would just many schools would just mask the whole school year. And we'll revisit it next year,
Yep.
that kind of thing. It just seemed like we were
Yep.
very blundering and oafish with the way that we looked at it versus nimble and flexible and reacting in the moment. Is that
Yeah,
fair?
that does summarize it really well. And there were very few people reluctant to challenge, a national narrative also. So, and then you have to realize that the school systems, universities included, are for some reason feel some sense of liability if they make the wrong decision or if they make a decision that's counter to whatever the CDC says. So there's a slow reluctance. There is a large reluctance to go against that in general. And I don't know if that is part of US society and a litigious nature of our population. I don't know if that's different than what's in European centers, but also you have to look at the public health agencies in European nations, especially like the Danish. They were much more responsive to real-time data than our own CDC has been. And so I think that's a big part of it. That's where the buck stops, is the CDC, because all of the other organizations sort of fall in line after what the CDC says. And then our national media, big part of that. And so, I know that our school systems were reluctant to make changes based on what the local health department was saying. So that's a big part of it. Politics was huge. And
I think it's our two-party system. That's
yep.
that's a big part of it, is because in order for us to have that flexibility, we'd have to have a political party on either side that's willing to concede that the last thing they did was not quite right. But in other words, if you put your political chips behind a policy and then a few weeks later you change it, well, then in our way of looking at it, that's one side admitting that they were wrong.
Yeah.
And then the other side would hop on to them and say, look, see, they did it wrong. Whereas
Yeah.
in a lot of the European countries, they have these multiple party systems where that back and forth is just, yes, they fight over there, of course, but it's different where like 3 or 4 parties might be seen as correct about how those things, and they share that blame and success a little bit differently than we do.
Yeah, but I have to say though, the one link though that always goes back to it is journalists. And so our national media conversation needs to be one that is willing to entertain all schools of thought. They can't just pick one side and stick with one side, because that sets the tone for the rest of the nation. And and so that's a problem. And yes, we have very polarized media. You're either extreme right or extreme left, somewhere in the middle, but never in the center. So and that sets a tone, and people are going to listen to what they normally listen to and get their information, and going to be on different sides of the aisle. And and then you took away the individual physician and patient from the conversation.
Right.
And so it needs to always go back to that, to the individual, to the actual data, real time. And so.
Yeah, that's really well said. I appreciate that. And this has been really productive and very helpful. I appreciate you spending an hour with me. Thanks, Dr. Johnson.
Oh, thank you for having me. I'm so glad we got to talk about this.
Yeah,
I think it's really important that we chronicle how this all went down for the future.
Yeah,
So
absolutely.
thank you for your show, and good luck to you.
All right.
Hey, where are you, by the way, Chris?
Yeah, good. So I'm in Kansas City.
Okay.
Hmm.
All right.
And we're done, by the way. I'm gonna cut this
Yeah.
part out, but
Okay.
yeah. So I'm in Kansas City, and I don't think I shared this with you, or you would maybe not have seen this on Twitter, but I jumped into the COVID conversation. Do you know who Amish Adalja is?
Yes.
Yeah. So he, of
Yeah.
course, is, a pretty big deal in
Mm-hmm.
terms of being an expert on this topic. And when the choir people started freaking out, I freaked out because I was like, oh my God, my job is over. Like our national organizations are going to the New York Times and talking about how horrible it is to sing and how dangerous it is. And I'm like, oh my God, we're gonna have schools shutting down their programs. Like this is gonna be a big deal. And so I reached out to him on Twitter, expecting him to ignore me, and I was like, "Can you come talk some sense into us a little bit?" And he did, and he came on, and that episode blew up. And so ever since then, I've been able to do a few more of these. Talked to several COVID experts and infectious disease people and epidemiologists and stuff. So it's been a fun little side project. Mostly, I just talk about music education issues, but this has been a fun series.
Awesome. Well,
Yeah.
good.
All right.
I
Well, you
gotta
have a good day.
give you a listen. Yeah, you too.
Okay.
Thank you.
All right. Bye.
Bye-bye.
Thank you, as always, for sticking around to the end of an episode. I hope you found something to chew on or something to think about. If nothing else, just a little bit of a history lesson on the last couple of years. And of course, I am sure that there were things in that episode that might make some people angry and make some people, or you just disagree with, or that's not how I remember it. As always, you can go to Choralosopher's Facebook page and talk to us about it. That is a type of Facebook group that allows people to have civil conversations about things that they disagree if they choose to. You can also email me at choralosophy@gmail.com, or you can go to the main page at choralosophy.com and put your thoughts in the form there on the main page. Support the show, as always, by liking, sharing, leaving comments, leaving ratings on the podcast app, even if it's a 1-star rating, and of course, going to patreon.com/choralosophy and signing up there. Last but not least, don't forget to use that promo code at ryanmain.com, graphitepublishing.com, mymusicfolders.com, and Sight Reading Factory. I'll see you guys later. Thanks for listening.